Hey friends, welcome back. We are talking about the very important topic of painful sex, when sex hurts, dyspareunia, with my good friend, Dr. Jill Krapf, board-certified OB-GYN, expert in lichen sclerosis and vulvodynia, which means pain of the vulva and pain with sex and all the things. Jill, thank you so much for coming back.
Thank you for having me. I'm excited to be on.
I'll put this in the show notes as well, but for people who want to go back, because as you know, like podcasts add up, right? Jill was on my podcast in episode 131, which was National Lichen Sclerosis Day. And she actually came back not too long ago at number 172 for vulvar itch, which I was like, we need to talk about vulvar itch. So if anybody who's interested in those, go back because Jill's an expert and we already have her on episode 172, vulvar itch, what could it be? So thank you for coming back to talk about your book this time.
Yes. Yes, I love coming back. Thank you for having me back. I feel like there's so much to talk about with all of these things, you know.
I'm like so excited.
Absolutely.
Yeah. And I like, so your new book, When Sex Hurts, Understanding and Healing Pelvic Pain, which you co-wrote with Andrew Goldstein, Caroline Pukel, Erwin Goldstein, and you
Yes.
doubled the size of this thing. I read the first edition. You doubled it.
Yes.
Basically.
We pretty much rewrote this book. So the original came out in 2011. So over 10 years ago. And really the reason that we revised it is because there has been so much that has happened in the research, clinically, just everything in the field of sexual health and female sexual dysfunction and painful intercourse that we had to. I mean, there's what we're practicing now doesn't look like what we practiced 10 years ago. And so it was absolutely necessary. And so this book is 80% new.
Wow. Yeah, it's amazing. It is comprehensive. It includes all the things. So I've been feeling so many because I'll post about it, right? And so people are like, does it include this? Does it include this? Does it include this? Because everybody thinks like there needs to be like one book for each different little condition. And it's like, it's very comprehensive and really includes many, many common and not common reasons for pain with sex. And not just pain with sex, but pelvic pain, having pain in your vulva when you're not having sex, like all of those little like caveat subtitles.
Yes, I mean the bottom line of this book is that there are causes to pain with sex, right? Oftentimes when people have pain in the vulvar area or the vaginal area, and everything looks normal, right? Or they go to their gynecologist and they're treated for the yeast infection or the urinary tract infection or what have you, and it's not working. In the past, we didn't know what to do. It was just, okay, you have vulvodynia. And I've had so many patients come to me saying, oh, they went through this entire journey. And then, oh, finally, my doctor diagnosed me with vulvodynia. And it always breaks my heart a little bit, honestly, because really vulvodynia is pain of unknown origin. So okay, that's kind of heartbreaking that you got that far and then finally you have an answer that's really not an answer. It's really not an answer at all. And what we know is that there are causes to this type of pain, whether they be muscular or hormone related or nerve related or inflammatory in nature. And so this book really covers the full gamut because there's always a cause to this type of pain.
How common is pain with sex?
Yeah, so if you look at the literature, it's about 16%, which I think is
you think it's underreported?
High. I think it's very underreported. I mean, you have to kind of differentiate it, right? There's people that have pain with intercourse at certain times in their lives, right? Like maybe after having a baby or maybe in menopause. And then there's people that have pain with intercourse from the beginning, and they've gone through many different doctors and they're having a hard time figuring out what it is. But if you take all comers, I think that it's much higher than 16%.
Yeah. So that's 16% of people who have sex at some point have had pain. And then what about just I have pain in the vulva?
Oh, because some
of those people aren't having sex then, right?
Exactly. And it's tough when we say sex, right? Because we know, and everybody knows, when you say sex, you're not necessarily talking about something going into the vagina, right? it's more inclusive than that. So when we say dyspareunia, yeah, that means pain with intercourse, but really what we're talking about is pain with insertion, right? With anything touching the opening, usually the vestibule, although it can be generalized, but the vestibule is that little area of tissue at the opening of the vagina. I tell my patients it's like the foyer of the vagina, and that's mainly where the pain is, usually. So that's what we're talking about here, but it can come in all forms, and it doesn't necessarily have to be pain. Some people have aching after intercourse. Some people have itching or burning, or, it can be described, or prickling, or, so many different ways to describe it. And it's really tough when you're talking about this, especially on social media, because I'm trying not to get banned. But also, it's really hard to have like an all-inclusive term for like pain down there. Like it's like, what's the term for that? How do we include everything there?
Yeah, that's so true. One thing I really love about this book is that it's also written for people who are partnered with the people who are having sex, to help them understand, or not having sex, just partner with people with pelvic pain. It's helping them understand, like, it's real. This is a medical condition. This is how you can be a supportive partner. So can you talk about like tips and tricks for communicating to your partner and or communicating to your doctor about what's happening down there?
Yes, this is an essential piece of the puzzle that really often gets missed, in my opinion. And I'm so thankful when patients come to me for a consult and they bring a support person, whether that be their partner or even a friend or a family member, some sort of support person, because it's really validating to have an exam and then have a doctor say, okay, your pain is related to the glands in the vestibule not functioning properly, or your pain is related to, too many nerve endings in this area. There's actually a physical cause. Just because you can't see it doesn't mean that it's not real. And so I think that, people with this type of pain often have times expressing it, because number one, it's not like they can go into work and be like, oh, my vulva really hurts, like it's not like someone, if someone has a headache, oh yeah, I have a migraine, or if they have back pain, oh, I have back pain, but like vulvar pain, it's not something, we're not there yet. And I hope we are there someday, but we're just not. So there's a feeling of loneliness that comes along with that. And then I've heard so many times people say, I feel so alone in this. I feel like I'm the only one that can't have sex, or I feel like I'm the only one that can't insert a tampon, or I feel like I'm the only one with lichen sclerosis or like a skin condition. This only one, that's awful to have something going on that you don't really understand. Your doctor doesn't know what's going on and you can't tell anybody about it. I think things are getting better with the support groups, like the Facebook support groups, Reddit, and the online resources. But as early as, I would say, even 5 years ago, there was really nothing. I mean, it was really hard. And so, I think we do need to talk about how to talk about this, right?
Mm-hmm.
I think that's a part of it. And it helps to talk, it helps you use the right language so you can communicate with your partner, you can communicate with your healthcare professional, your doctor, your nurse practitioner, or what have you. And the other thing that I think is great, so Carolyn Pukal is a sex therapist and researcher, very prolific. Like she does a ton, she has a big sex lab up in Canada, and she's fabulous. She's published a ton on these topics. She also includes, okay, what happens after you don't have pain anymore? What if everything's fixed and then all of a sudden here you are and you're having issues with libido, or you're having issues with intimacy, right? Or, oh, okay, now it doesn't hurt, but then you have to jump the hurdle of, okay, this is a different relationship than it was before. So there's a whole chapter on like, okay, what do you do when you kind of fix the problem, which is something that no one ever talks about. I see it, I see okay, yeah, I don't have pain anymore, but I have no desire, right? Yep. We see that all the time. And so all of these pieces of the puzzle are very, very important, and we need to talk about them more.
I thought that was super awesome that was included in the book, because you don't even think about it, right? Like the whole goal is to solve the pain. And you're like, yeah, but we're actually getting really good at solving the pain now. So we got to talk about what happens after. And I see this in, in erectile dysfunction too, of like the guy gets his erections back, but then,
and then what?
Yeah, but then like it's still a sexless marriage, right? And we thought the erectile dysfunction was the problem.
Yes, and it turns out that it's the tip of the iceberg. It's bigger than that. And the other thing is with chronic pain, chronic vulvar pain or vulvodynia, what have you, a lot of these patients have been to like 10 different doctors. Like they have spreadsheets, logs, diaries, records, binders. Like this has actually become their job, right? This has become a part of their identity, whether they wanted it or not. And so it does get a little difficult because you have to acknowledge that, yes, this is a part of the history. This is a part of them now, right? And then if you do make everything better and they're able to do things that they couldn't do before, sometimes there's a bit of loss of identity that we have to recognize. Even though it's a good thing that they feel better, there's also, it opens up a lot psychologically. And that's why it's so important to have a sex therapy or a therapist piece in all of this. We're not saying it's all in your head, but we are saying that anytime that pain is chronic, there's always a psychological component. And that also needs to be, it needs to be recognized for sure.
Yeah. Like I'm not holding my breath for like when that statement actually gets accepted by both patients and doctors. I think doctors are seeing that more, right? The role of the brain in perceiving pain and making pain worse. But I feel like the lay population, like people look at me like I have two heads, because I think it's this like stigma of saying it's in your brain, which is kind of technically true, but not in the like insulting, dismissive sort of like style that people, used to take from that statement.
I've thought a lot about this actually, about the it's all in your head statement, because you're a urologist, I'm a gynecologist, we're medical doctors. We have a lot of experience in treating people with these different conditions and sexual conditions. And yes, there is a head component, like there is, right? But I think the underlying issue with it's all in your head is that there's no resources that are given, right? Like basically it's a blame. It's like, okay, you're causing this and there is nothing that you can do to make it better. Like you're basically swirling down this spiral. Whereas I think a better message, and that's not true. Like we know that goes without saying, right? That is not true. But if we don't recognize the mental component to pain, then we're missing a big piece of the puzzle, and we're missing a big piece that people can have control over. So for example, I have a lot of patients that have tight pelvic floor tight pelvic floor muscles that cause pain with insertion and all kinds of different bowel and bladder issues. And when we talk about, pay attention to your pain, you'll notice that sometimes things get worse when you have more stress, right? So that's something that we recognize. And then it's like, but here are the things that we can do to counteract that. When you feel stressed and when you feel it's affecting your body and your body's manifesting that, then here's 1, 2, 3 things that you can do. This is your toolbox. These are your resources. Go ahead and go into a quiet room. Go ahead and do 5 diaphragmatic belly breaths, right? You can go ahead and do some yoga-based stretching, some hip openers. So I think that's the difference. The dismissive, it's all in your head, is blaming the patient. It's basically not giving them a diagnosis. It's saying that they caused the problem and it's not giving them any resources. And it's saying, I don't see anything, so it must not be real, right?
Yep.
Whereas, I think that we need to change that narrative. But it can't go too far in the other direction where we're not recognizing the head at all.
Yeah, totally. It's not all just a skin condition in the vulva. It's not all just in your head. Oftentimes it's both. There's a duality to it. What's interesting in your book too is the role of the partner's behavior on the pain. And you talk about it a couple of times. And it said people who perceive their partners as kind and understanding report more intense pain than women whose partners have responses that promote adaptive coping. And I'm like, What? Like, that's fat. You're like, the nice, I'm going to give him a pronoun, but like the nice guy, like, could actually be not making it worse, but like there are behaviors that are even better than just kind of this like passive, kind, understanding, like, take your time instead of like actually helping people solve the problem. I love that that's in the book.
There's actually quite a bit of literature on this, and it's so fascinating, just how people's dynamics work with different situations. And there's definitely like a facilitator connection that can occur where someone's in pain, the partner responds by, like, basically, whether it be avoidance or coddling or, like taking on this caregiver role. And there can be like some secondary gain to different things. So it's very interesting, like unwinding some of these patterns, especially when they've been going on for years and years. It's hard to unwind these patterns. And I see this even with people, like with how they treat themselves. Like there's even like almost like a superstition component sometimes. So I have patients that get better, like especially my vaginitis patients, my patients with vaginal discharge. When they get better, there's certain triggers for them. It's like, okay, I can't wear this bathing suit because last time I wore this bathing suit, I got a yeast infection. And so, and that makes sense. This is all human nature, right? We need
Yeah, it's
to
how our brain works.
recognize. Yes, it's how our brain works, and we need to recognize these things because we want to feel good. Like we don't want to be in pain. We don't want to have chronic itch. We don't want to have a discharge. And so it makes sense that you would, have certain behaviors that would facilitate things like that. But those behaviors can sometimes be maladaptive as well, and we have to recognize that too.
Yeah, I love it. I love it. To me, I'm like, people are going to be hearing this for the first time, like the role of your relationship in like facilitating, improving and solving it versus keeping it status quo. Right. There was, you had talked further of like, if you're a partner of somebody with pain with sex, the best partner response is having a partner who engages in what researchers call facilitative responses, affection and encouragement to cope with the pain in an adaptive way, such as by focusing on pleasure, deep breathing, or positive thoughts while experiencing the pain. Of like, not just being like, okay, well, not today, or, worst case scenarios, like the gynecologist said everything looked fine. I don't see what your problem is, right? Like there's all these different types of responses versus like, let's try to like move forward, find tips and tricks. Let me support you in that instead of just being this like either unhelpful or passive participant in your journey.
Yes, and this is so important. And it's interesting because I think sometimes when people are living with this, they kind of gravitate towards one of two scenarios, which tend to be on the ends, the extremes of the spectrum, right? I would say most patients probably gravitate towards the avoidance side, whereas it hurts. So we're just not going to do it, like we're just not going to do it. And then sometimes it goes to the extreme. And I see this, especially in my menopausal women, where it's like, okay, we're not going to have sex, so we're not going to do anything, right? Like anything. And then the other obvious extreme that's equally as harmful, or maybe even more harmful, is okay, I'm just going to grunt and bear it. I'm just going to like push through it. I'm just going to, I know that I'm going to get this infection. I know it's going to hurt. I know this, I know that, but I need to just do it, get it done. And that is definitely not helpful either. I think, what people think about less is, hey, how can we have some fun? Let's be creative. What can we do? Okay, this isn't working. Let's not stop. Let's not keep going. Let's do something else, And I think that sometimes just that gentle reminder, or just seeing it in writing or seeing someone else's experience, it kind of just opens up the brain to, oh my goodness, all the different possibilities. Like, what's the goal here, right? The goal is not to put a penis inside a vagina. The goal is for people to feel connected, for people to have pleasure, for you to feel, sexy, for you to feel, for you to feel good, whatever people get out of it for their own relationship and especially for themselves. So sometimes we have to go back to like, what's the goal here, right? And there's so many things that people can do. It's not a cop out. It's basically just being creative and bringing fun. And same with, so a lot of times my patients struggle with kind of going from dilators to intimacy with their partner, because I have a number of patients, especially my vaginismus patients, who are like, yeah, I can get to like the second biggest dilator, like I can do it, like no problem. But when I try to have sex, it's just like it's a no-go. It just doesn't happen. And so, it's like, well, have you tried? You have to bridge the gap, right? Like this is the important middle part that may not be as obvious to people. It's always kind of like, okay, the extremes, but what's the work that we have to do in the middle? And how can we make this as enjoyable as possible? Let's laugh about it. My patients that have been the most successful are the ones that like joke about things, right? Like I have a patient who has diazepam suppositories, which is basically like a muscle relaxant compounded into suppository. You can insert it either in the vagina or rectally, and it helps to release the tight pelvic floor muscles. And so her partner started bringing her suppositories at night on a silver platter and called them her booty bullets. And he's like, here's your booty bullet. And like, they would just laugh, and like, it was fun and funny, and they're like, okay, and she did great. Like she got better fast, and it was a good transition. But it's like, you almost need that just take it back like just a layer, so it doesn't feel as heavy as it really could be.
Yeah, I love it. Thank you for giving people ideas too. It's awesome. You talk about a lot about stress, sex, and the gut. Can you talk about like the role of the gut and what you see with people with like irritable bowel syndrome related to pain with sex? Like, what's your concept of how that's all related?
There is so much to this that we don't understand yet. The gut is very much connected. And I can think of it in a couple different ways. Number one, anything that's in the pelvis that's causing negative sensation is likely affecting the pelvic floor in some way. So if someone has Crohn's disease, or if someone has irritable bowel syndrome, or if someone has anything gut related, it's similar to like recurrent UTIs, or, it's similar to fibroids or endometriosis. Obviously some of these things are more severe than others, but all of these things are pain generators. And so any pain generator can definitely affect the muscles, because the muscles are very responsive. And then if the muscles are engaged and really tight, that can affect the pudendal nerves as well. And so that all can contribute. So in that way, gut can be one of the pain generators. The other way to consider it is that think about the mucosa and the microbiome of the gut. And what are the similarities and differences between the gut microbiome and the mucosa of the gut and how it responds to inflammation? And then compare that to the mucosa of the vagina and the bladder and the urethra, and then consider the vestibule. And so we know that these microbiomes are likely slightly different, but the concepts are similar. I've had a number of people that have made dietary changes, like say they have gluten sensitivity, and they cut out gluten or limit gluten, and they notice that their vulvar pain improves, right? So we know that there's connections here, and I'm excited to see where the research is going to go with the microbiome, with inflammation, because I think that there's a lot to be learned from the gut and how to apply it to the other mucosa in the genital tract and the urinary tract.
I love it. I want to switch gears and talk about oral birth control pills. Like what's trending on the internet is like now all oral birth control pills are bad, and like it's the internet loves black and white, and I'm like, these are medications that have made family planning possible, have made women put their careers first possible. Like these are amazing drugs, and I can't just be like they're bad, right? I will not jump on the trend. That said, I think we've really downplayed what these oral birth control pills do to our hormones and then our hormone sensitive structures. And you guys talk about in your book the role of Yaz, which is a low dose blockbuster birth control pill. Drospirenone is the generic to it. And the role of these, would you call them low dose or very low dose birth controls? Is that kind of like the word for these things? Yeah, okay.
Yeah, absolutely. I mean, compared to the doses that were back in the 50s, yes, these are low dose birth control
if people like
pills,
have heard about that as a generic. And so somebody did a perspective, you write about this in the book, somebody did a prospective study of women's genitals and sexual function prior to starting Yasmin and then after 3 months. And they actually like not only measured the structures, but then asked women like how their sex life was. And they said there is decreased clitoris blood flow, decreased clitoris size, decreased labia minora, decreased libido, fewer orgasms, and more pain with sex. And I think women get blown off, or like we don't even think the birth control is an issue at all. I just think it's really quiet of like the role of pelvic pain, low desire in we're like our good friend Rachel Rubin says, you play with hormones, there are side effects. What do you see in your clinic with this?
Yes. So any medication has good effects and bad effects, or has positive effects, negative effects, however you want to say it, right?
Trade-offs.
Sometimes, yeah, trade-offs, right? Because these are medications that are taken by mouth that travel through the bloodstream. So they're going to affect the entire body, including the brain. There's a lot of medication, there's a lot of times when we give a medication, like say an antidepressant, let's use that as an example. If I'm going to counsel you on taking an antidepressant, we're going to talk about the reasons why you would take such a medication, right? A decreased anxiety, decreased depression, so you can improve function and so forth, sleep, right? But we're also going to talk about, okay, it may cause nausea when you first start taking it. It may cause weight gain. It may cause decreased libido. It may cause decreased orgasm. You're going to talk about the pros and you're going to talk about the cons. And for some reason with birth control pills, that's not really emphasized as much, right? It's kind of taken for granted, I would say. And then the role of sexual health has been not talked about with birth control pills in the past. Sure, we'll talk about blood clots, right? But we don't talk about the potential for pain with intercourse, right? And some of this has to do with the literature, but really those findings have been around for quite some time now. The issue is that you have to think of these things as side effects. Not everyone is going to have them, right? If someone takes a medication, you'll see, 8% of people developed nausea with this medication. Well, 82% didn't, or 92% didn't. I can do math. So you have to, it's not going to happen to everyone. And you have to think of birth control pills in the same way. There's and it's probably based on genetics, right? If you're going to take a medication and develop nausea, it probably has to do with your genetic makeup in some way, right? So you can apply that to birth control pills as well. There's going to be a certain subset of people that take birth control pills and it affects the way that their glands that produce their natural lubrication work. And it has to do with how hardy or how strong your receptors for testosterone are. And this, there's some pretty compelling findings out there that show that. I think that we could probably prove, show it over and over again to make that stronger. But we do know that when we give people who develop pain in the vestibule, after they've started birth control pills, when we take them off of the birth control pills and we replenish testosterone and estrogen to that area, they improve, right? I mean, you can't get better. It can't get better than that. Is there a randomized control trial showing this? No. But the problem is that that requires a lot of funding, and it's hard to fund something that we already know works. So that's kind of the issue with that. I mean, if someone wants to do that, by all means, but it's going to show that it does work, because we've been doing it clinically for like 15, 20 years. So that's kind of like the bottom line with it. Nothing's all good, nothing's all bad, but you have to think about your medical history, your personal risk factors. Unfortunately, there's not a commercially available blood test that can tell you how strong or weak your testosterone receptors are. I mean, it's possible because we used it for a study, but it's not cost effective at this point. And then the other issue with sexual function and birth control pills is when we look at the research, it's really looking at a very wide view of this, because there's benefits to being on birth control pills from a sexual standpoint as well. It's not all decreased libido, pain with intercourse, and so forth, which, like I said, only a small subset of people will develop. Obviously, if you're on birth control pills and you're not as worried about getting pregnant, then perhaps you have a better sex life, right? And there's a lot of things that go into that. So, the literature is all over the place. Some studies say that it improves sexual function. Some studies say that it doesn't improve sexual function, but we have to look at the methodology and how we're gathering this data. And it's really so broad that it's really hard to draw these conclusions, because we're not getting down to like the nitty gritty of how the body works. We're just looking at whole population studies. And that's what makes it a bit confusing.
Totally. I have two thoughts. Number one, the people who are started on birth control really young, like in the pubertal world, like I've started on it at 15 because I've just had heavy periods and cramping ever since, I was a mid-teenager. Are you seeing more sexual side effects in them because they never kind of fully went enough years with their hormones in puberty? Number one, not that anybody's looked at this, but things I'm curious about. And then number two, do you think it'd ever be like, hey, be on birth control, but also be on vaginal estrogen, so we never get kind of that blockade going on? Thoughts about those two things?
Yes. So there's really very limited research on this. My clinical experience, based on my clinical experience, what I think is that if someone starts birth control pills really early, I do find that their clitoris is smaller.
I find that too. Like that's why I asked the question, because it's like, you look and they've been on birth control for 15 years and they started, mid-teens. I agree. That's what I'm finding also.
And they have less, there's less growth of the labia minora as well. And so there are changes that do likely occur when someone starts a medication that suppresses ovulation and changes the hormonal milieu at such a young age during a very important hormonal time period of puberty, right? Now, do we have all of this documented and in research? No, this is needed. I mean, this is important. I think that this is a part of a consent process, right? These are the things that we should be talking about. If someone has acne or if someone has irregular periods, which we would expect when someone's in their young teens to have irregular periods, their HPA axis or the connections from their brains to their ovaries to the uterus, they're fumbling, right? They're like a toddler trying to walk. It's a time when not everything is really functioning the way that it does when, later into the 20s. And so a reflex is to put people on a medication to regulate that. But honestly, we don't really know what the sexual effects of these medications started so early are. And then the question is, well, if a clitoris is smaller or if labia are less developed or smaller, then what is the implication of that? Does it matter? Right? And we don't have the answer to that as well. We don't know what the functional implications are of these things, but I think it's important to know because what if there are functional implications? Then, are we not consenting people? Would somebody go on a birth control pill at the age of 12 if they knew that they couldn't have orgasms, later in life? Or, how would you make that decision? These are all there's more questions than answers, but these are all very thought-provoking
I'm glad we're at least
questions
thinking
that we
about it.
should be asking.
Yeah. I mean, I just think about it.
Sexual health is health.
Yeah. And I always hold up the mirror because I treat men as well, right? So I'm like, what if I had a 14-year-old boy with acne or something, and I said, yeah, I can put you on this medication, but it might make your penis not be as big as it could be if you weren't on this medication. They would be like, hell to the no 100% of the time. Nobody would sign up for that, right? And so it's like, if we're truly being fair, like, we need to know what's happening. We just haven't done the research, which is kind of irritating.
Yeah, absolutely. The research needs done. And I mean, when you put it that way, yeah, how can we just put people on medications, kind of without knowing all the implications, right? I mean, we do that all the time, but to not even talk about it, right? To say like, there's a possibility of this, or there's a possibility of that. It just seems, it seems like we're way behind when it comes to vulvar and vaginal health compared to penile and testicular health.
Yeah, totally. I think that the systemic testosterone for women is kind of coming into the zeitgeist a little bit more. And you talk about this in your book with the role of testosterone in pelvic pain. And you're talking about one study shows that women with higher androgen levels, I'm assuming this is just, exogenous, have less work-related neck and shoulder pain than women with low androgen. And differing levels of testosterone may explain some of the gender-related differences in pain perception. In your practice, or if there's studies, I haven't seen the studies. In your practice or in studies, do you know you have a woman come in with a vulvodynia or whatever's going on? Does she have a low serum testosterone? Can you supplement that testosterone and improve the pelvic pain? Has anybody played with that?
So yeah, there's a couple ways to look at this. One is looking at hormones obviously are something that it's a substance produced in one area that affects something in another area, right? They travel. And in order for them to affect whatever area they're going to affect, the endpoint has to have a receptor, right? So when we're thinking about testosterone, we need to think about, okay, where are the testosterone receptors the most plentiful? And then what effect is this having? We know that there's receptors in the brain, and we know there's receptors in the glands and in the vestibule and the vulva and the vagina and so forth. But we still don't have like a full understanding of all the places in females where testosterone plays a role. I think in the rest of our careers, I think what we're going to find, at least what I'm hoping, is we're going to really value the importance of testosterone in the female body. Not only with the brain and libido, which I think that has started. And actually there's really good literature on testosterone patches for HSDD, all out of Europe. It's interesting that they discontinued them because the demand was not there, which is so wacky wild. But I wonder if that would change now, right, with the climate of how things are right now.
Yeah.
But there's nothing FDA approved here in the US for low libido, but it's more than just libido. We know that there's a role for vaginal dryness, pain with intercourse. So we call it hormonally associated vestibulodynia. It kind of falls into that GSM or genitourinary syndrome of menopause category. But we also see it obviously in perimenopause, postpartum, a certain low subset of people on birth control pills or hormonal contraception that stops ovulation, right? But the pathophysiology, meaning like the way that this all works, like the workings are the same in each of these cases. It's just the underlying root cause may be different. We see the same thing in a 20-year-old on birth control pills who has that side effect because she has weak testosterone receptors that we see in that 58-year-old that is having pain with intercourse. And we give the 58-year-old a diagnosis of GSM, and she has FDA approved medications to treat it. Well, for the most part, not testosterone, but we have a much better handle on that than we do that 20-year-old who thinks she's completely alone because all of her friends are having sex and she basically can't, because it burns so much and it stings so much, can't even insert a tampon. So, my hope is in the rest of our career, we're going to really realize the full potential of testosterone and how we can treat people based on low testosterone, based on risk and benefit and alternative. I think that this is the next frontier of sexual medicine.
Yeah, I think so too. I take the opportunity to say this as much as I can. I'm literally talking to my brother, who's not medical. He is like a dude's dude. And we're talking about testosterone for him, and he has an ex-partner, and she went in to get testosterone and her doctor said no. And I'm like, WTF? And I'm like, well, really the only legit, air quote, legit reason for a woman to get testosterone is low desire. And he's like, what the actual hell? That the only reason a woman can get testosterone is to sleep, usually with a man. Yeah, he's like, why? Yeah, and like he cracked my brain open with that. It's absolutely insane that is the only reason you can get testosterone. Is to sleep with another human. It's absolutely
really
crazy.
I know. And, like people that are obviously have normal levels of testosterone, like when I say normal, I mean like physiologic, they have more energy, they feel better, they sleep better, they have, better muscle mass. There's so many benefits. And the problem is that people realize this, they know this. And because there's not a very accessible way to treat people, people are going out and they're getting pellets, right? They're getting these these basic super physiologic doses that are implanted under the skin. And the problem with this is that when that testosterone pellet, so it's basically a device that's inserted under the skin that's impregnated or, contains testosterone at a pretty high dose. When that is implanted, someone gets this like jolt of testosterone. They feel awesome because it's like taking steroids. Rush. I mean, like there's a reason. Exactly. It's a steroid rush. And then that level dissipates and decreases down until they don't feel good again. And then they do another one and they get a big bolus again. So it's almost like going on a roller coaster. You're going to the top of the hill, you're going down, you go up to the top of the hill again, you're going down. And we really don't know what the safety is of those changes, right? Mm-hmm. It's not all about levels. When we look at menopause, for example, and vasomotor symptoms, which is kind of like VMS, the new hot term for hot flushes and night sweats, right? When we look at that, it's not necessarily the level of estrogen that plays a role, but it's the difference in the level. It's the fluctuation that leads to the hot flushes and night sweats. And if we think about it that way, it's not just about having a lot, having a little, having a normal amount or like within range. It's about, okay, what's happening high and low? What's the pattern? And so forth. And so when you're talking about pellets, we don't know what the safety is of having that high level, sure. But what I'm more worried about is actually the safety of having the high, low, high, low, high, low, because we know that has caused other issues and other conditions when we look at other hormones, right?
Yeah.
So that's why I'm a proponent of I would, when I treat people with testosterone systemically, I treat them with a topical gel. So, and that keeps the doses stable. You always want, stable doses are what you want, that are able to be controlled and changed, instead of something that is basically implanted, gives you really high doses, goes down to 0, gives you really high doses again, and can't be changed. That is very dangerous.
Yeah, totally. Thank you for explaining that and telling us what you do. One last question before we wrap it up. This has been an awesome talk. Recurrent yeast infections. Dun, dun, dun.
Yes, everyone's that's favorite like topic.
Its own podcast. But tips and tricks. Oftentimes it's not a yeast infection, so getting a proper diagnosis, right? So just like a couple minute thoughts on the curse of the recurrent yeast infection.
Okay. So here's my baseline thought with it. If someone is having, think about yeast infections like the canary in the coal mine, right? It's an alert that something is not working properly, right? So if someone's having yeast infections, you have to go back and think, okay, why? I tell my patients all the time, yeast lives in and on us in low levels. We cannot eradicate yeast from our body. It's just not how we work as organisms, right? But why is there yeast overgrowth? Right? The overgrowth is what causes symptoms. So, is that related to hormonal factors, the microbiome? Is that related to genetics, right? And you need a suppression medicine because we can't change genetics, or you need a dietary, dietary changes or what have you to work with the genetics that you have, just like high blood pressure. If you had family history of high blood pressure, then you're going to decrease salt in your diet and you're going to eat whole food based diet, and you may require a medication to bring down your blood pressure. Same thing with yeast infections. Some people, they just have a genetic predisposition. There's research out there that have identified the actual genes that are involved in not recognizing overgrowth of yeast and letting it just go wild, right? And so there are people that fall into that category that basically need those, daily life kind of changes to kind of keep things in check, and they may need a little suppression medicine to kind of keep things in check as well. And then there's other people that there may be something else going on, whether it's not actually a yeast infection, it just everything feels the same because you have the one type of nerve receptor in that area. So of course we think everything feels like a yeast infection or a UTI because that's kind of what we were conditioned to think when something's wrong in that area. And so it's really about getting down to the bottom of it and really thinking of yeast as kind of the response and not the main thing to target. There's something deeper going on, and that's my job in the office, is to figure out what that is and then to give you options to get it managed.
Perfect. Do you have a preferred either yeast diet or suppression medication?
Yes. So as far as diet goes, I'm very careful about diet because I do not want to be restrictive. I have patients that have a history of eating disorders, right? So for me to say, oh, you can't eat this, you can't eat that, that's harmful. So basically, diet is very individualized, as we know. And so it comes down to just talking to the patient, telling the patient what we know about how diet may or may not play a role based on their exam and what we think is going on. And then just kind of feeling it out of what changes or substitutions can be made. People often know their triggers, I find. And then as far as suppression medications, we have a number that are available. So there's oral medications that are azoles, that are basically yeast suppression medications that work quite well, that can be used in a long-term regimen. One that you may have heard of is fluconazole. And then there's two newer medications that have been on the market for the past year, a little over a year, almost 2 years at this point. And those can be used for long-term as well. One of them is for menopausal women or women who've had a tubal ligation, just because it has such a long half-life that because it does work so long, we don't always know what the reproductive implications are. And so there's that medication. And then there's another medication that just got approved recently for a once a month dosing. So there's things out there. They may not be well known. So that's why it's important to see a specialist if first line things aren't working, but we do have experience with these things and we'll gain more as we move forward, and hopefully more things will come down the pipeline that will be more targeted and really help for longer. So that's my hope.
Love it. So you are starting private practice in Tampa, Florida.
Yes.
September.
I am starting an expansion of the Center for Vulvovaginal Disorders. It's going to be my own practice down in Tampa, Florida.
Can people get on the waiting list, or how do they hook up with you?
Yeah, I'm going to start booking. So the building is not done yet, but it will be in September. And I'm going to start booking through the center, hopefully starting in July. So we'll open that up. I will honor all of my existing patients. So if you have been a patient of mine in the past and I have seen you in person in the DC office, then you can continue as a follow-up patient with obviously follow-up patient pricing. And then I will be offering consults to new patients who want to see me or who are able to see me because of my new location. So all of that I will share on social media as well as my website, www.jillkrapfmd.com. So that's where you can find me.
Awesome. I'll put it in the show notes. Thank you so much for talking. Everybody who has a loved one or suffers from this, When Sex Hurts is an amazing book. Link is in the show notes. Go get your copy. Thank you so much for writing a second edition.